to say this is our site. Sierra Leone site, we are 5 people, and these are the names, so that we can capture your presence in full. So today, we are delighted to have our call again, and this is for the month of August. We are having today, our presenter is already online, Jillian from CHAI, actually representing the consortium for POC. She's going to be making a presentation on some of the experiences coming out of the pilots that are happening in a few countries around integrating POC in viral load programs. I just want to make a little. I just want to make some clarity. We as a community, we advocate. Our backbone programming is centralized testing for viral load. But we know even in the best case scenarios, centralized testing may not be able to adequately serve the entire communities that need to be served. So we know POC has a place to complement centralized testing. So there have been a few pilots that have been happening, and there are a few lessons that have been learned. And this presentation is going to be highlighting some of these experiences that have been picked out of the pilots that have been happening. So I want to take the pleasure to welcome our presenter, who's going to make a presentation for about 20 minutes. And after that, we request you to mute. Ibrahim, mute yourself. So I said, whoever is not on page, you're not speaking, you mute yourself, okay? So now I want to take the pleasure to welcome Jillian to take us through the presentation that she has for us today. I will have a few announcements, but I can bring them at the end. We are planning to have a face-to-face meeting that is coming in October, and we will be happy to invite you. Communications are coming along before the end of the week. Please, when you receive them, act quickly and do the needful. We want the people who are going to attend. We are happy that the headquarter team has actually joined, and I think at this moment transfer a few rights to them, just in case there is anything. I'll transfer some hosting rights to the headquarter team. Dr. Pasco and Rov, you're welcome. Okay, so Jillian, please take the floor.
Okay, great. Thanks, Charles. Great. Can everyone see my screen?
Yes, yes.
And you hear me? Great. All right. Well, thanks, Charles, for the introduction, and thank you, everyone, for joining us today. As Charles mentioned, I'll be discussing point-of-care viral load for targeted populations and some experiences that CHAI, ASLM, UNICEF, and respective ministries of health have in introducing point-of-care technologies. So today's session objectives are to summarize the populations who can most benefit from point-of-care viral load testing, to introduce existing supportive systems that should be considered to assist with the introduction of point-of-care viral load testing, and to understand the initial experience of offering point-of-care viral load testing by leveraging integration onto existing GeneXpert devices. And to accomplish these objectives, the session will be structured as per the following. So I'll provide a brief introduction to point-of-care HIV viral load testing, and then we'll go through a few case studies that were conducted in Malawi and Zimbabwe of piloting offering point-of-care viral load through integrated testing on existing GeneXperts. And we'll focus mostly on how these ministries of health planned in order to successfully integrate point-of-care viral load testing, as well as some of the key considerations for successful implementation. And then we'll conclude. So just as a brief background, in 2017, we estimated that there were about 14 million HIV viral load tests conducted across worldwide, which is quite remarkable. And current projections estimate that we probably will achieve almost 90% coverage of viral load testing for people living with HIV who are on ART in the next 5 years. And as everyone is familiar with, viral load testing is critical to monitor the effectiveness of ART in order to avert HIV-related morbidity and mortality. So given these tremendous accomplishments of scaling up access to centralized viral load testing, I wanted to take a step back and mention some of the challenges that we're experiencing as we scale up viral load testing. We know based on the session that was held a couple months ago that there is low utilization of viral load testing results. So what I'm just summarizing on this slide here on the left is a few studies that were conducted across multiple countries, which were looking at the percent of patients with unsuppressed viral load who actually receive a follow-up viral load. And you can see that in the majority of countries, this still remains below 50%. And additionally, in a couple countries that reported the turnaround time from when the person initially was identified as having their first unsuppressed viral load to their follow-up viral load, we can see that the time is quite long, 6 months and longer. Additionally, on the right-hand side, I've summarized some data from MSF across 6 countries and multiple sites in which they looked at the rates for which patients who have unsuppressed viral load and then were deemed to be failing their treatment were actually switched to second line. And you can again see that the rates are quite low. On average, the switch rate was about 33%. And the consequence of this data is that we don't have sufficient effectiveness of our ART program. So we're doing a great job of placing people on ART, but we're not necessarily doing the best job of monitoring them. And so what are the challenges that are contributing to these poor utilization? Well, we know from the session 2 months ago that there's a lot of demand side factors. So clinician knowledge needs to be strengthened. Patient behavior is a contributing factor, but there's also health systems issues that we can focus on, and that will be the focus of this talk today. So as everyone on this call is familiar with, centralized testing requires a lot of steps from sample collection through testing and then getting the result not only back to the clinic, but back to the patient so that clinical action can be taken. And based on looking at multiple countries and depending on the maturity of their viral load program, the amount of time that it takes to get from sample collection to result return to patient can be at least a month or even multiple months. But we know that there are point of care tests that can be offered at the point of service, which can compress each of these steps down to just within multiple hours. And therefore, a patient can get their sample collection and receive their result all in the same day. And this can enable same-day clinical action. So which point of care products are there? As of right now, there is one point of care viral load test that has received WHO pre-qualification, and that's the Cepheid Gene Expert. As well, we have the Samba-2 test from DRW, which is approved by the European Union. And then additionally, we have the Abbott MPIMA, which was formerly called the Alere-Q, which has been approved for early infant diagnosis testing and now has a viral load test, which is currently undergoing review by the European Union and the pre-qualification program. So to frame the rest of the conversation, I'd like to just summarize a problem statement as follows. We know that demand for viral load testing services is not quite keeping pace with the rates of increased ART initiation for people living with HIV. And this suggests that additional molecular testing capacity is required. We also know that ART access has been tremendously decentralized, which is remarkable, but we need to consider how we would then reach all people living with HIV who are on ART in order to monitor them appropriately. Centralized lab systems have been designed to maximize throughput, but they often do so at the expense of speed, and this can lead to missed opportunities. And we know from results that I haven't presented here that point of care testing has been demonstrated to be very impactful to increase rates and timeliness of clinical action when offered for EID and CD4. But we also know through those experiences that management of decentralized testing fleets can be quite complex if you don't have the appropriate supportive systems. So if we take a step back and think about the overall viral load testing cascade, we know that about 19% of people who are living with HIV who are on ART, when their viral load is tested, will be suppressed. And so, or unsuppressed, I should say. And so it's those patients that we are most concerned about and for whom we might want to have a more rapid result. So we can think about offering rapid testing for this second viral load so that perhaps we can facilitate faster switch and perhaps also offer more coverage for this second viral load. We also know there are certain priority patient groups for whom having an elevated viral load is more consequential. For example, pregnant and breastfeeding women for whom we would like to achieve viral suppression not only for their own health, but in order to prevent vertical transmission. As well, there are populations for whom rates of suppression are much lower, such as children and adolescents. And so we might want to have more rapid access to routine monitoring for those populations. But what do we need to do in order to offer point of care viral load testing, given all of the investment in the centralized testing system and other systems? Well, one idea would be to integrate testing with existing platforms that already are placed in countries. We need to think about, when we're designing a point of care and centralized lab system, how we can reduce infrastructure costs, service costs, training and mentorship costs, et cetera, and be efficient, while also balancing the need to increase access to testing. And integration can facilitate better program coordination, as well as ensuring high testing quality. So additionally, I wanted to just point out a few other considerations when offering integrated testing. So point of care devices the costs of point of care devices are much more dependent on the number of tests run. So the cost per test can really vary widely depending on utilization. So if you run more than 5 tests per day, your cost per test can be about 50% less than if you run only 1 or 2 tests per day. So ensuring that you're having maximal utilization for point of care testing is very critical. And one way to ensure increased utilization would be to pool volumes across different test types, for example, viral load, EID, TB. And this can enable increasing access to point of care testing at sites that would otherwise not be able to afford a point of care test if they only focused on one particular test type. So an analysis that we did across 15 countries in sub-Saharan Africa showed that there's about over 2,000 gene expert devices that have been placed through the TB program, which is an estimated investment of about $35 million. And so we'd like to think about how we can best leverage that existing investment. And as I mentioned, the remainder of this talk will really focus on what are the supportive systems that need to be put in place to ensure the success of point of care, leveraging our vast experience with centralized lab testing and the supportive structures necessary to ensure the success of those systems, as well as our experience in introducing point of care CD4 and EID. So to summarize this background, we know that viral load testing has and will continue to scale up, but that results are not being utilized optimally. And that point of care has previously been demonstrated to reduce the time to result receipt, as well as increase the proportion of results that are returned to patients. Integration offers an opportunity to increase access and minimize costs for introduction of point of care testing. And then we need to ensure that there are robust supportive systems. So at this point, I'll switch to highlighting a few key lessons from pilots that were conducted by the Ministries of Health in Malawi and Zimbabwe that were supported by CHI and UNICEF. And I hope some colleagues from these pilots are on the call and during the question and answer session can perhaps provide a bit more in-depth knowledge for these case studies. And again, we'll focus mostly on planning how to introduce point of care viral load through integrated testing, as well as some of these supportive systems, and then we'll conclude. So to start with, the first consideration when introducing a new product would be appropriate site and product selection. And Malawi has had successful experience introducing point-of-care CD4, and as well last year, or in 2016, published in 2017, they demonstrated the tremendous impact of point-of-care EID in facilitating timely diagnosis and ART initiation for HIV-positive infants. And so they wanted to think of a plan of how they could increase access to point-of-care testing for people living with HIV. And as I mentioned, in 2016, the GeneXpert EID test received WHO pre-qualification, and so Malawi started thinking about how they can more widely offer this test. And in thinking that through, they also thought that they should also consider the introduction of the GeneXpert HIV quantitative viral load test. And through an analysis looking at the 90 existing GeneXperts that were already in place in Malawi in 2016, it was estimated that the utilization of those devices was less than 35%. And by just doing a desk review of the utilization, we determined that about 75 of these GeneXperts that were placed across 64 sites had sufficient excess capacity to potentially be utilized for the, HIV testing. And then what we did is we looked at the historic TB volumes, and then we projected the additional volumes that would be added for EID testing by looking at the PMTCT cohort size per facility. And then we estimated that about 15% of the ART cohort would be unsuppressed and hence should be prioritized for point-of-care viral load testing. So we projected those volumes across these 75 sites and looked at whether we would exceed the optimal capacity of the GeneXpert devices. And 10 of the district hospitals that have existing GeneXperts were selected based on the volume projection showing that they would not exceed their optimal capacity. And so a pilot was conducted for 6 months at these 10 facilities. Additionally, when we were looking at product and site selection, one of the benefits of these district hospitals is that there are already existing transport systems and training systems that were in place at these hospitals. And so the point of care test introduction was piggybacked onto existing infrastructure. When we also think about site and product selection, it's important to think about who will be offered tests and how the lab will handle multiple test types and multiple sample types. So in Zimbabwe, they also conducted a pilot across 8 facilities. And I'm just listing here the patients who are prioritized for point of care testing. So the qualitative or EID test, which can be utilized with whole blood or DBS, was offered to all HIV exposed infants who were in need of a virological HIV test as per national guidelines who presented at the facilities that were offering point of care testing. The GeneXpert TB test uses sputum, and all TB suspects in need of TB screening were offered the TB test during the pilot. And I will note that during the pilot, Zimbabwe was transitioning from using expert for targeted populations, so HIV positive TB suspects and drug resistant TB suspects, to all TB suspects. And hence their volumes were expected to increase for TB testing during this pilot. And lastly, Zimbabwe decided to prioritize point of care viral load, which uses plasma, for certain target patient groups. And I've listed those target patient groups below, as well as some of the justification for why Zimbabwe chose to introduce point of care viral load in this fashion. So their guidelines recommend that pregnant and breastfeeding women have a 6 monthly routine viral load test as opposed to an annual viral load test. And point of care was hypothesized to perhaps help facilitate that. As well as it's expected that based on the ZIMFIA data, that about 13.5% of people living with HIV on ART in Zimbabwe are unsuppressed, and hence point of care viral load could help confirm failure in that proportion of patients. So as they were introducing point of care testing, integrated point of care testing, it was important to work with the laboratory to understand how to prioritize the 3 or even 4 different sample types and the processing that's required for those different sample types, as well as which tests to prioritize. And having clear SOPs to guide this was part of the success of this pilot. Moving on to training and mentorship, both countries leveraged, as I mentioned, existing training infrastructure. So utilizing a training of training model where regional training of trainers were certified as master trainers in each province or district that was offering point of care testing. And those trainers were certified in the operation of the point of care devices themselves. Then we also provided step-down trainings at the provincial or district level, on-site trainings and user certifications, and then developed regular mentorship activities that will be utilized as we transition from the pilot to more implementation of point of care testing. So just to highlight the training of trainers, generally the material covered in that is very dependent on the curriculum provided by manufacturers. The training really focuses on how to operate the device, how to provide service and maintenance, etc. Then there are site level trainings, again, which go over specific SOPs. And these site level trainings, in addition to discussing the lab specific workflow and processing of samples and operation of the devices, also focuses on the lab clinic interface to ensure that when point of care testing is introduced, that the clinical side of things are aware and that you can maximize the impact of the results. And then, as I mentioned, there are mentorship programs that are now designed that will be led by master trainers, and that will be done on a biannual basis to ensure appropriate training. So moving on, the next supportive system that's really critical to laboratory testing is ensuring you have a comprehensive quality management system. So in both Malawi and Zimbabwe, there are kind of four main QA systems that are in place that will help facilitate ensuring high quality point of care testing. So the cartridges that are run on these point of care devices have built-in internal quality controls that are in place in order to ensure the issuing of accurate results. And we can monitor the error rates that are issued when those IQCs fail. As I mentioned, there's also mentorship and supervision programs that have been designed to ensure, to monitor the testing over time, as well as to provide remedial action when appropriate. And then I'd just like to highlight two specific areas of quality assurance. One is external quality assurance. So we know for centralized labs that EQA programs are critical. And during the pilots, there were no existing point of care EQA programs. So Malawi started with duplicate testing for the first 10 samples, both HIV viral load and EID per site, where they used the point of care result for patient management, but also sent a duplicate sample to the centralized lab in order to check the concordance. And moving forward, EQA programs will start likely the second half of this year, which will be led by LabCoP in Zimbabwe and SHU in Malawi. And there are now proficiency testing panels available through Quasi that are compatible with the Gene Expert and as well as the MPIMA for both EID and soon to be for viral load. And I also believe that CDC has panels that can be used for EQA as well. I'd also like to point out one unique feature of point of care devices is that they have inherent remote connectivity capability, which can allow real-time data monitoring of performance. So this is complementary to your traditional proficiency testing or EQA programs. It can help to identify both device-related issues for prompt service if you're seeing the same errors over and over again, or you see that there's a module down, as well as to monitor operator proficiency. So if you see that error rates for a particular user are much higher than his or her colleagues, or if you see that error rates are creeping up and you look at the error rate codes and see that most of the errors are due to operator error, this can trigger mentorship, on-site mentorship and remedial action. I'll just note that the MPIMA can connect to POC Lab or Data Point as a dashboard, as well as Gene Expert connects to the GX Alert. And in both Zimbabwe and Malawi, the goal is that all POC viral load and EID devices will be connected to their national dashboards by the end of 2018 to allow national monitoring of device performance. Lastly, I'll just touch on both supply chain management as well as waste management. As we decentralize point of care testing, obviously there's a lot more that needs to be considered in order to ensure robust and continual availability of point of care testing products. And there's a lot of challenges that need to be overcome in order to successfully ensure an uninterrupted product supply. And we do believe that one aspect of connectivity is that it can help to monitor stocks, which can enable better forecasting and quantifying, as well as tracking of inventory. And then, as everyone should be aware, the GeneXpert, many of the GeneXpert virological tests for HIV and other viruses do contain GTC, and thus they need to be disposed of appropriately. And so both Malawi and Zimbabwe worked with the supplier during the pilot to ensure access to appropriate disposal of these cartridges. But as they plan to scale up virological testing on GeneXperts, there is a significant, non-insignificant amount of resources that have to be put in order to ensure appropriate waste disposal. So lastly, I just wanted to kind of highlight some of the impact that point of care viral load testing had through these pilots. So this is a bit of a busy slide, but on the left-hand side, what we're looking at is just overall testing volumes. So as I mentioned to you in the beginning, ensuring optimal utilization of a point of care device is a good way to minimize cost. And what we can see in the graph on the left-hand side of baseline, that we had an average utilization of about 38% across the pilot sites before the pilot, and this went up to 63% through the pilot. And Zimbabwe had targeted about 75% as optimal, so we still didn't exceed capacity. And you can see, as I mentioned, that the TB testing volumes increased. Both EID and viral load testing was well accommodated. And based on an analysis that Malawi conducted based on their utilization, they saw that the projected cost of offering TB and HIV testing on the was about $100,000, and that combined, and that integration could have saved about 40% across both the TB and HIV programs. So I think there is a lot of cost saving to be realized through integration. When we look at who benefited from point of care viral load testing in the middle graph, we can see that about 45% of all viral load tests were offered to targeted patients, including pregnant and breastfeeding women in this dark blue, and those suspected of failure in the light blue. And then about 55% of tests were reported if you did. And then when we look at the impact of offering point of care viral load, we can see over time the proportion of unsuppressed patients who actually had a documented clinical action. So whether that was enhanced adherence counseling or second line switch, depending on their need, that we went from having less than 5% of patients having a clinical action documented within 1 week to 78% of patients. So just integrated testing should carefully consider capacity at the facility and of the device in order to ensure that all testing demand can be met. And this is definitely a strong prerequisite to the introduction of point of care testing, or any testing for that matter. This would apply to centralized testing integration as well. Patient selection and prioritization should ensure that the highest priority specimens are tested promptly. Robust training and mentorship is important to ensure high quality testing. And this should be linked strongly with robust quality management systems, waste management systems, and procurement and supply chain systems. And these are all critical to building sustainable support for POC testing. We also saw that integration testing did not compromise the existing TB testing program, so rates of treatment initiation stayed the same, and turnaround times and volumes were all accommodated. As well, integration increased access to point of care EID, which I did not show you, as well as viral load testing services. So just to conclude this session and then open up for discussion, I want to highlight that substantial progress has been made in scaling up access to centralized viral load testing, and that I think programs are really coming into maturity in offering viral load monitoring for their PLHIV who are on ART. But certain populations and settings may be better served by accessing more rapid viral load testing, which can be offered through point of care. There are inherent advantages and weaknesses to both systems, and therefore appropriate product and site selection must be done to build an optimized viral load testing network. And that this optimized lab network is supported by strong training, quality management, and supply chain to ensure success. And lastly, the case studies that I walked you through in Malawi and Zimbabwe demonstrated the importance of systematic and appropriate site selection to enable integrated testing success, and that this is a way to offer more decentralized and rapid viral load testing. So thank you. Charles, I'll hand it back over to you.
Okay, Gillian, thank you very much for that very elaborate and clear presentation on the experience from countries that have piloted the integration. So we want the audience to react in form of asking questions or seeking clarity or adding to what has been shared in the next about 20 minutes. So I open up this to the discussion. So everybody is invited to actually react to what has been presented. There have been quite a number of communications on the chat box. I will ask Nicholas to keep reading out some of the communications that have been coming through the chat box. Meanwhile, if you have not put in your question into the chat box, you can put up your hand. We hope we'll be able to see you and ask you to respond. So I open it up now. Okay. Nicola, I hope you people are hearing me, eh?
Yeah, we are getting you.
You're getting me, okay. So I know you have, you could be having quite a number of questions that have come through the chat box. Do you want to read them out?
Mainly there have been introductions in the chat box.
Okay.
Maybe Ian could stop sharing the screen so that people can raise up their hands. Okay.
Yeah.
Thank you.
So Jillian,
sorry, I just couldn't figure it out for a second, but I think I've stopped sharing my screen now.
Okay. So okay, there's a question here. Yes. Martin from Uganda, you can.
Thank you, Charles. I want Jillian to tell us how easy is it reporting into the national system where you have multiple testing labs across the country? And maybe the second would be about issues regarding quality. How can you ensure quality of the results that are coming out of the multiple labs?
Okay, so Miriam, so have you removed your screen sharing? I want to be able to see the people who want to pose questions.
I believe I have. If I have not, someone let me know.
No, you have. You have removed it. It's fine.
Okay, fine. So.
Thank you, Jillian, for your presentation.
Computer, if you're not joined by phone.
Oh, mute yourself if you're not speaking, if you're not on stage. Okay?
So my question is about the cutoff values. As we were rolling out the new regiments, the INSTIS, DTG in particular, our National Advisory Committee requested us actually to consider lowering a cutoff from 1,000 to maybe 200 or lower because of the low level viremias and DTG monotherapy. Now, this point of care testing machines, already we had a challenge with DBF samples where cutoff is less than 989. So what is the cutoff value for the point of care testing samples? Is it qualitative, like we had, semi-quantitative, like we had with Samba, where it's either less than 1,000 and 1,000, or it's more of a quantitative scale for the cutoffs?
So, Gillian, you can respond to those.
Okay.
Meanwhile, the response, you can also be writing questions on the chat, because I may not be able to see all of you, and we don't want to miss your questions, okay?
Okay, great. Thanks, Charles. I'll take the first question first. So the limit of detection for the gene expert viral load test is 40 copies per mil, and it is a quantitative test. The MPIMA viral load test will also be a quantitative test, and I believe the threshold has not yet been publicly released, but I anticipate that it will be higher than that 40 copy per mil because it uses a lower volume of plasma. So that's just the anticipated, I can't actually say what the anticipated limit of detection is, but when the product is commercially available, it will be noted. And in the presentation, if we distribute the presentation on slide 8, I noted the limit of detection of each of the products, so you can review that. There was a question about national reporting. So it's a great question. As of right now, as I noted, these were just pilots. And so they were 10 sites in Malawi and 8 sites in Zimbabwe. And we had to use paper-based mechanisms in order to integrate the results from the point of care into the national system. But as I noted, both Malawi and Zimbabwe do have national LIMS dashboards that are being put together. And the goal is that the point of care devices, the dashboard that they transmit their data to, would integrate directly into that national LIMS system. Because you're right, at a national level, you need to know how every one of your labs is performing, the volumes of tests, the results, et cetera. So I think that's a critical component of ensuring the success of point of care testing. I'll note, for example, that in, I believe, Kenya, who does have point of care testing for EID, right now you can see on their dashboard both the point of care and the conventional system. So it is feasible to do this, and it's a critical part of ensuring kind of an optimized and integrated, centralized and point of care system. And then I think you asked a question about quality assurance. So I'm sorry it wasn't clear in the presentation, but there's a few mechanisms that are in place to ensure the quality of testing. One is you can use a traditional EQA. I think that could become very challenging when you're talking about hundreds or more sites that offer point of care testing. But additionally, you do have, as I mentioned, connectivity. So you can monitor the error rates, which are an indication both of operator performance as well as device performance. And you can provide ongoing monitoring of those error rates to see if you need to flag a particular site that may be struggling to perform appropriately. And you can also use ongoing mentorship, site supervision that you normally do for any kind of lab system. So I think it's the idea is to take the existing quality management systems that are in place for centralized systems and just adapt them for the point of care application.
Yeah, we have some questions in the chat. I think I'll read them. They are 3 in number. The first one is from Kabuje, and he's saying, for Malawi and Zimbabwe, viral point of care was not connected to national dashboard. Then how was the data managed by the program? That's the first one from Kabuji. Then the second question is from Pasco. What is the minimum number of tests per day that is required for a cost-effective point of care viral testing? Minimum number of tests per day that is required for a cost-effective point of care viral testing. Then the other question is from Daniel Kimani, and he says, how do you operationalize the 3 testing types at sites? That is DBS, plasma, and sputum. Do you have different days or hours to run different tests? And then the other question he's asking is for you to elaborate more on waste management. Yeah, those are the three questions from the chat.
Okay, thank you. So I think the first question I already mentioned. So the minimum number of tests for point of care to be cost effective. So that's a bit of a loaded question because it depends what your cost effectiveness threshold is. What I can say is if we look at the cost, if we look at a fixed cost of the device based on current costs of device, we've projected that at 4 tests per day, the cost per test is around $4.90. And if you have 12 tests per day, that's about $1.60 per test. So you can see that it really ranges widely. And if you go below 4 tests per day, you're obviously going to be above $5 per test. I will point out, though, that in general, when we're talking about point of care testing, and as I highlighted through the integration discussion, you don't necessarily need to think about just the one specific test type. So for EID, for example, we know the volumes are always going to be quite low unless you place a device at a high volume site. So thinking about if I have 3 EID tests in a week, but I have 10 viral load tests in a week and 10 TB tests in a week, then perhaps I'm reaching more of an optimal utilization. So thinking through that per site is really important. And then the question on elaborating on waste management. So the challenge with the waste management is you need a very high temperature incinerator in order to dispose of the GeneXpert virological cartridges for some of them. And so what many countries are considering right now is do they have any incinerators in country that reach this temperature? I've heard that perhaps some cement factories have incinerators that reach these high temperatures. And so you need to, I think each country is thinking through how would you access incineration at this high temperature. I will note that GTC is a byproduct of most PCR reactions. So in centralized labs, you're already handling GTC waste, but it's in a liquid form, and you have a way to do that. In the point of care situation, this small amount of GTC is in the solid waste, and it's obviously a small amount because point of care tests are once off. But I think it's really important to work with Cepheid as the supplier because they are aware of this issue, and each country should engage with Cepheid to discuss what the most appropriate waste management system for their country is. And I don't know if any colleagues from Malawi and Zim are on the call, but if they are, they could speak to what they themselves are considering, or any other country that's on this call who's started to think about how they would dispose of the HIV or HPV cartridges, for example, on the GeneXpert. Were there other questions?
Yeah, actually, 2 more questions in the chat. They are coming from the team in Sierra Leone. It's a big team, stay together. The first question is, what are some of the key challenges with POC, if any? Then the second question they are asking is, how timely was the data generated at the testing point sites reported to the national considering poor network connectivity in low resource settings?
And also there's another one.
Yes, John.
Yes, thank you, Julian. I would like to, did you actually measure the proportion of patients who got their results within that given day when they were played? Because the state point of care is in to bridge that gap and have patients coming to the clinic, see a doctor, have their blood played and get the results. So what proportion of people actually came in within this study and got the actual result of that same day as you reported?
Sorry, you're a bit far from the microphone. So you were asking the proportion of patients that...
The proportion of patients who could have gotten their results on the same day their sample was played.
Got it. Right. So basically, how many people waited for their result?
Proportion. Right?
Yeah. Okay. So I'll just 1 second here. So the proportion of patients that actually received their result on the same day was 14%. So that means that 14% of patients waited for the result to be available, and it was given to them in that same appointment. whereas the remainder of the patients had to come back in a second visit, and did come back in that, within 7 days for the majority of patients. First, I think there's a bit of feedback. And then the question from Sierra Leone, I think, is quite a lengthy answer. So the challenges with introducing point of care, I think I tried to point out some of the systems that you need to think about. So you're managing supply chain, training, quality across multiple sites, up to maybe hundreds of sites. And so ensuring that you have the right systems in place to routinely monitor all of those aspects can be a challenge with point of care testing. But I think we do have experience from CD4 now with EID, as well as the TB programs, and now with viral load, perhaps, that we can learn from what are the strengths and weaknesses of different approaches to ensuring monitoring across multiple sites. When it comes to connectivity, it's a great question. So we all know how challenging connectivity can be in various parts of the countries in which you're working in and living in. And there are different solutions. Some devices require you to, have Wi-Fi or can transmit across the cellular network. But I think that this can be a challenge. This is something that we at CHI are looking into, actually, of how we can come up with better systems to ensure connectivity in very fragile connection environments. But it is definitely not an insubstantial issue. And I think there are circumstances when you still just have to rely on paper-based transport when connectivity is just too fragile.
Yeah, okay. There are still two questions in the chat.
Okay.
I think the first one was already asked, but maybe the answer wasn't so clear. That was from Daniel. He has asked again, how do you operationalize the 3 testing types at the site? That is DBS, plasma, and sputum. Do you have different days or hours to run the different types? That is the question he asked. I think he needs the answer. And then the other one is from Dave Jojok, and is asking, I think he wants to know the cadre of who are testing. Is it technicians or the clinical team? And he says this has implications on adherence to quality. Yeah, those are the 2 questions, Chair.
Great.
Yeah, maybe I can also seek some clarity about the cost.
Yeah.
You say if you are doing like 12 tests a day, it comes to $1. This $1, is it overhead? Is it a total cost for the tests? Because at least we know that it is not $1. So can you say something a little more? What does that $1? If I did 12 tests on a gene expert for viral load, would it cost me $1 each of those tests?
Sure. So I'll have to pull up the assumptions that went into that, and perhaps I can discuss that with you afterwards, Charles. But we did look at HR costs. It's a true cost per test. It's not just the cost of the product itself. And then to get at the 2 other questions. So since we use gene experts that were already placed at these facilities and they were already placed in the lab for TB testing, the operators of the gene experts in these pilots were all lab technicians. And I think in general, because of the current requirements to operate a gene expert in terms of infrastructure, most gene experts are placed in labs and will be operated by lab technicians. I think the Abbott and Pima, perhaps the Samba, can be placed outside of lab settings in clinics. And we have seen, at least for the MPIMA for POC-EID, that nurses and non-laboratory staff are very capable of operating these point of care tests. And we haven't seen that error rates or training varies by lab or non-lab technician. And that Mozambique, for example, most of their point of care EID devices are operated in clinics by non-lab staff. And then in terms of prioritization of the different sample types, it's really a great question. And generally what we saw is that in Malawi, for example, they had each lab sort of decide for themselves how they wanted to operate based on turnaround times. Essentially, the way each lab worked was as a sample came in, I think the lab figured out the order in which they wanted to process. In general, because the devices are owned by the TB program, we encourage the sputum testing the TB testing to be prioritized, as well as the EID testing, since that's more of an emergency test. In Zimbabwe, they used whole blood for some of the EID tests, and in Malawi, it was DBS. And as you know, DBS needs to dry for a few hours before it can actually be processed. And then plasma for viral load was sort of the lowest priority in a way, keeping in mind the storage conditions that are required to store plasma if needed. But I think this is a question that's really important. And in general, what we experienced is that each lab wanted to work out for themselves how they would operationalize this. I don't think that any lab, at least in these pilots, had dedicated testing days for TB versus HIV. I do know in Nigeria, we're doing some hepatitis work where they've added HCV testing to existing gene experts. And there, they started out having 2 days a week that were HCV days and 3 days a week that were TB days. And that's how they decided to offer services. But that then requires you to ask patients to come in on particular days or to have the right storage conditions in your lab to only run tests on those particular days. So I think I don't have a definitive statement that this is how you should do things, but I think that it's really important for each lab service to determine their appropriate SOPs for how you would prioritize test type as well as the actual test itself.
Okay, I think...
I'm requesting there are 2 important questions in the chat. The first one is from GetNet Hairu. He's asking, did you evaluate the error rate of POCs for viral loads? How was it acceptable? And then the other one, I think, is from Clement, is asking to avoid having a parallel system between POC and the conventional laboratories. Were there any mappings done?
Great, those are both great questions. So I will say that the error rates were monitored. I didn't present them here. In general, we saw that the error rates with viral load testing were slightly higher than the error rates with TB testing. And there's 2 reasons for that. One is generally anytime you introduce a new test, you do have errors. As I noted, these pilots were about 5 and 6 months respectively. So over time, we expect that those error rates will come down. And the main contributing factor to those high error rates was insufficient volume of plasma being added to the cartridge. So in follow-up training, what we really encouraged was we really emphasized the importance of adding the full 1 ml to the cartridge before running the test. And then Clement, it's a great question about mapping. So again, as these were pilots, we initially, and these are existing sites that already were offering gene expert testing. We didn't add additional sites. These sites had already been determined, and so we just took advantage of them. Moving forward, both in Malawi and Zimbabwe, they're creating comprehensive point of care scale-up plans. And those comprehensive scale-up plans, in case any additional device would be placed, would certainly be mapped against the existing point of care infrastructure as well as the conventional infrastructure to think about how to optimize the system across the board.
Okay, Gillian, thank you very much. Thank you very much, the audience, for being engaged. It's been a very exciting and very interesting discussion. I'll just make a few closing remarks and then we will have some announcements. As I began in my opening remarks, is the backbone for our viral load programming is centralized testing. And as a community, that is our stand. And as I said, that of course, even in a best case scenario, there are many challenges on either side, POC and centralized testing, but either way, both of these systems need each other. The centralized testing as a backbone would benefit greatly from a complement POC program. And the POC and conventional programming should work together as one program so that there are no parallel systems running for POC and centralized testing. And of course, as highlighted by the presenter, lots of system issues need to be considered. The coordination, data management, quality assurance, waste management, logistics management, and so on. And these are results that have come out of a pilot. We are not saying that go tomorrow and overthrow your centralized testing and begin, POC programming. It should be planned very well. It should be discussed with all the stakeholders in country and see a system moving in a harmonized and well-coordinated with all the other benefits that a country would need, like for instance, data management and the program monitoring, well considered. And then in a phased way, we can start integrating POC into our centralized programming, which should be and should remain the backbone of the national programming. So thank you very much. So as we wind up, I mentioned we have an upcoming event where as a community, we will be congregating together as we end our first year of implementation. We will have a face-to-face meeting. We've been meeting online, but we want to meet face-to-face, and it will be a great moment for us. We are going to have a meeting between the 15th and 17th of October. We will have this first meeting in Uganda. You're going to be receiving this week, you're receiving invitation letters, and especially the team leads. We want you to really play a very central role in following up these invitations. We want to invite about 5 people from the country team, but also we ask our CDC in-country teams to also support their team members to attend the meeting and some other stakeholders to attend. So please, when these invitations reach, we'll continue following up with you. Help us to follow up to get the feedback from the ministries of health on who is coming to this meeting, on how the 5 people are selected, but also helping us to link the communications, the letters that we are going to send to the CDC country team so that the communications go. So we are looking forward to our next our next call, which is coming in next month. We will be sending you more details about this next call that we are going to have. We are going to be discussing some of the touchy issues that have also been discussed here. We have one of our next call is going to be handling. There has been many questions on waste management, but also on demand creation. We are going to be handling some of these issues, but we are going to be sending more pointed communication about this. Otherwise, for now, I want to say thank you very much for being around on this call. Let us remain engaged on WhatsApp. The discussion continues. We could not exhaust all the questions, but we can continue asking the questions on WhatsApp, on Slack. This presentation will be available on Slack. Please make sure you link up there so that you can get all these communications, and the WhatsApp discussion should continue so that we continue learning from each other. Otherwise, thank you very much for now, unless if there is any I don't know, Pasco, is there anything you want to communicate?
Hi, Charles. No, thank you. I think it was an excellent session. I see that there were more than 50 connections and with 25 people behind the screen. I mean, it really means that our community of practice is very popular. So I just hope that for the next one in September, we have that same or even more people online. So thank you very much for your participation.
Okay, thank you very much. Please let us know how many of you, these 50 also connections had so many other people in the background that we didn't know. Actually, Uganda has like 15, 20 people right here, and so many others. I've even seen Kagando in Tanzania. Kagando as a hub. I'm excited about that. Kabuje and your team, thank you very much. Please let us know who out there was on this call, and that will be great for our communication. Thank you very much. Have a nice time. Bye.
Thank you. Thank you too.
Bye-bye.
Nicolas.